Hello, my friends. I'm Dr. Julia Parker, urologist and senior health specialist. And today, we're going to have one of the most important and potentially life-saving conversations about medical tests that doctors routinely order for seniors over 70, but that may actually cause more harm than good, and that you have every right to question before agreeing to them. I believe it's time to bring this critical medical information to light with evidence that the healthcare system rarely communicates clearly to older adults. Because when we understand which medical tests provide real benefits versus which ones create unnecessary anxiety, false diagnosis, and dangerous overtreatment in seniors, we don't just protect our health. We make informed decisions that can literally extend our quality of life and longevity. So, welcome back to this space where patient advocacy supersedes medical protocol and where informed decision-making replaces blind compliance. Whether you're over 70 yourself or caring for an elderly loved one, this information could be crucial for avoiding unnecessary medical interventions that do more harm than good. The truth is uncomfortable, but liberating. After 70, the human body responds differently to medications, to anesthesia, to recovery, and to stress. The very same test that might be preventive at 50 can set off a cascade of complications at 75. And too often, what begins as a routine check turns into a series of procedures, follow-ups, and treatments that don't improve survival and can seriously diminish day-to-day well-being. I've watched this pattern play out countless times across my 25 years in geriatric urology, but I've also seen something beautiful. When older adults ask clear, focused questions at the right moment, the momentum shifts. Doctors slow down. Options open up. Harms shrink. Quality of life rises. So today I want to hand you a simple, powerful toolkit. 9 questions, 9 clear, respectful, evidence-informed questions that help you and your doctor decide what is truly necessary and what is not. Before we dive into the 9 questions, let's anchor ourselves in reality. Medical care after 70 is not a one-size-fits-all algorithm. It's a personalized risk-benefit conversation in which your priorities, your independence, your comfort, your ability to garden, travel, read to your grandkids, sleep through the night, or walk without fear, matter as much as any lab value. And yes, there are tests that are invaluable even in advanced age when symptoms or risk factors warrant them. But the starting point is not do everything. The starting point is do what matters and only what helps. With that in mind, let's begin building your toolkit. Question 1 to ask your doctor. What decision will this test help us make, and how will the result change my care? This sounds simple, but it's the heart of avoiding overtreatment. Every test you take should be tied to a specific decision that changes what happens next. If the test won't change your management, you should rarely take on its risks. Ask your doctor to walk you through both possible outcomes, a positive result and a negative result, and what each would practically trigger. If a scan just to be safe won't alter treatment either way, it is not truly necessary. If an annual screening would only discover extremely slow-growing findings that you would never choose to treat, then the test doesn't serve you. Asking this question transforms a vague protocol into a concrete plan. Sometimes your doctor will realize, mid-conversation, that the test is a habit, not a necessity. And sometimes you'll discover that the test really does guide an important decision for you specifically. Either way, you've turned on the lights. Question 2. Given my age, health, and priorities, what are the absolute benefits and absolute harms of this test over the next 5 to 10 years? We all hear relative numbers. This reduces risk by 30%, but those can mislead. What you need to know is absolute risk and absolute benefit. Out of 100 people like you, how many are helped and how many are harmed? Ask your doctor for numbers, or at least for concrete estimates. Ask about the risk of false positives that lead to more procedures. Ask about the risk of complications from sedation or bowel prep or biopsies. Ask about the chance that discovering a problem would actually change your lifespan or your functional independence. In older adults, the absolute benefit of many screening tests shrinks while the absolute harm, falls, delirium after anesthesia, bleeding, infection, medication reactions, grows. You deserve to see both sides of the ledger clearly. Question 3. What is my realistic life expectancy and functional outlook, and how does that change the value of this test? This is a brave question. It's not about giving up. It's about being precise. A healthy 75-year-old who walks daily and manages her own life has a very different calculus from a frail 75-year-old who has multiple chronic conditions and needs help with daily tasks. Many screening tests only show a mortality benefit after 10 or more years. If your realistic life expectancy is less than that, or if your priority is comfort and independence rather than long-term risk reduction, then most screening no longer makes sense. On the other hand, if you're robust and active, some tests may still be appropriate. Ask your doctor to discuss expectancy in terms of ranges and function. If my odds of benefiting are only meaningful beyond 10 years and my likely horizon is 8 to 10, what does that mean for me? This isn't pessimism, it's wisdom. The goal is to match care to reality, so your remaining years are lived fully. Question 4. What are the downstream consequences if this test finds something small or unclear? This is where the cascade begins. A tiny nodule seen on a CT scan can lead to repeat imaging, a biopsy, a hospital stay, and months of anxiety, without clear benefit. A borderline lab value can trigger a medication that causes dizziness and a fall. Asking this question forces everyone to look ahead. If your doctor says, well, if we find X, we'd likely do Y, which needs sedation, then Z, you can ask, do those next steps actually improve my outcomes at my age? Or do they mostly create risks? Sometimes the best path after an incidental finding is watchful waiting. Sometimes the best path is to avoid the initial test entirely. By surfacing the downstream steps, you can decide whether the first domino should be pushed at all. Question 5. Is there a simpler, safer alternative that gives us the same decision-making power? This is the question that opens doors. Could a stool-based test replace a colonoscopy for someone with prior normal screens? Could an ultrasound replace a CT when radiation matters? Could a short follow-up exam replace an immediate biopsy? Could home blood pressure monitoring replace aggressive in-clinic testing that spikes readings? Doctors are trained to aim for the gold standard. But after 70, the best test is often the one that answers the question with the least harm. Alternatives are not about being less thorough. They are about being appropriately gentle and equally informative for the decision at hand. Question 6. For chronic conditions like diabetes or high blood pressure, what targets are appropriate for me, and what's the risk of being too aggressive? Overtreatment isn't only about tests, it's also about numbers we chase. Many older adults are kept on tight glucose targets that raise the risk of hypoglycemia, confusion, and falls. Others are on multiple blood pressure medications, aiming for youthful numbers that leave them dizzy and dehydrated. You can ask, what target keeps me safe without pushing me into side effects? What's the simplest regimen we can use? In many seniors, slightly relaxed targets improve well-being without sacrificing meaningful outcomes. This question invites your clinician to adjust from autopilot to customized care. Question 7. If treatment is recommended after this test, what are the trade-offs in function, independence, and quality of life, not just survival? This question brings humanity back into medicine. At 72, the trade-off might be a year of fatigue for a small survival gain. At 85, it might be a high risk of incontinence in exchange for treating a slow-growing condition that may never harm you. Name the outcomes that matter: walking without fear, thinking clearly, sleeping well, staying in your home. Ask, how likely is it that this treatment will preserve or impair those outcomes? Let the metrics of your life, not just lab metrics, guide choices. Question 8. Can we try watchful waiting or time-limited trials before committing to invasive steps? Medicine often presents binary choices: do it or don't. But a middle path exists. Watchful waiting with structured follow-up can be the safest option for slow-moving conditions in late life. Time-limited trials, 3 months of a gentler medication with clear goals, can reveal whether benefits are real before you accept long-term side effects. Ask your doctor to define success criteria in advance. If my symptoms aren't better by this date, we stop. This approach keeps you in the driver's seat and prevents treatments from continuing out of habit rather than benefit. Question 9. What do respected guidelines say for people my age and health status, and are we following them or going beyond them? You don't need to memorize guidelines, but asking this question signals that you want care anchored in evidence, with a thoughtful rationale for any departures. Good clinicians will appreciate the invitation to align with best practice. And if your doctor is recommending something outside the norm, you'll hear the reasoning, and you can decide whether it aligns with your priorities. Sometimes there's a good reason to go beyond guidelines, like a strong family history or a specific symptom. Sometimes it's just inertia. Either way, you'll know. Let me share a story that illustrates how these questions change outcomes. A fit 78-year-old woman I'll call Eleanor came in for a second opinion after being told to schedule a screening mammogram and a CT scan because it's been a while. She had no breast symptoms, had previous normal mammograms, and had a low-dose CT a decade earlier with no issues. She asked me, "Dr. Parker, will these tests change anything?" We walk through the 9 questions. The likely downstream consequence of a small, indeterminate finding was more scans, a biopsy, and possibly surgery, all of which she said she would not want unless there was clear evidence of benefit. We considered alternatives: clinical breast exams, symptom-based monitoring, and discussed her life expectancy and goals. She chose to skip screening and continue attentive self-care. 2 years later, she remains active, hiking with her grandchildren, unburdened by medical cascades. Did she miss something? Possibly. Did she avoid harm that would not have helped her? Very likely. And that is a win. Now, I want to connect these questions to specific scenarios you may face. If you are an older man whose clinician orders a PSA blood test simply because it's routine, ask questions 1, 2, and 3. How will this result change my care? What are the absolute chances this test helps me versus leads to biopsy and treatment harms? Given my age and health, would finding a slow-growing cancer actually extend my life? In many men over 70, the answer is that screening does not improve survival, while the cascade of biopsy and treatment can cause infection, incontinence, and loss of vitality. If you choose surveillance or skip screening, you are not being reckless, you are being strategic. If you're a woman over 75 being scheduled for a routine mammogram after a long history of normal results and no symptoms, bring questions 1, 2, 4, and 7. Will a finding change my management in a way that improves outcomes for someone my age? What happens if we find a very small, slow-growing lesion? What are the chances that surgery or radiation will help me versus reduce my function? For many older women, the balance shifts toward watchful waiting, with a focus on overall health, strength, and symptom awareness rather than screening. If your gastroenterologist suggests a just-in-case colonoscopy after 75 when your prior exams were clear, Ask question 5 about alternatives like stool-based tests and question 8 about watchful waiting. An invasive procedure with sedation may add more risk than benefit in many seniors, while non-invasive testing and symptom-driven evaluation can keep you safe. If you live with diabetes or hypertension, bring question 6 to every visit. Are we chasing numbers too hard? Could we simplify my regimen to reduce dizziness, falls, or low sugars? Often, gentle adjustments, fewer medicines, slightly higher but safe targets, restore energy and confidence without sacrificing safety. If someone proposes a CT, MRI, or PET scan to look around, ask questions 1, 4, and 9. What decision does this scan inform? What happens if we find something tiny and ambiguous? Is this consistent with guidelines for someone my age, or are we exceeding them without clear benefit? The goal is not to say no reflexively. It is to say yes only when the path ahead truly serves you. I also encourage you to use a simple 3-step script whenever you feel rushed. First, pause and name your priority. My top goal is staying independent and clear-headed. Second, ask question 1. How will this test change my care? Third, ask for time. If this isn't urgent, I'd like to think about it overnight. That little script protects many people from being swept into decisions they regret. Let's talk about decision-making with family involved. If you're a caregiver or adult child, prepare together. Sit down before appointments and write the 9 questions on a card. Decide in advance which outcomes your loved one values most. In the room, resist the urge to solve everything instantly. Instead, keep the conversation on the patient's goals. If you sense momentum toward aggressive care that doesn't fit, it's okay to say, "We appreciate your thoroughness. Could we discuss what watchful waiting would look like?" Or, "Can we prioritize comfort and function here?" Being an advocate isn't about being confrontational. It's about slowing down enough to align care with values. There is another piece to this conversation, and it's one many of you ask about. If I'm choosing fewer tests, what can I do to stay strong, energized, and resilient? I'm glad you ask, because avoiding overtreatment is only half of the equation. The other half is proactive, compassionate self-care that supports circulation, cognition, sleep, and mood, foundations that help you live fully and reduce the need for intervention. Here are simple, gentle pillars that reliably help many older adults without adding medical risk. First, movement with purpose. 10 minutes of daily walking after meals improves blood sugar control, circulation to the brain, and sleep that night. Add 2 minutes of gentle balance practice, standing at your kitchen counter on one leg, then the other, to prevent falls. Small, consistent actions are the secret here. They deliver benefits that no pill can replace. Second, protein with color. Aim for a palm-sized portion of protein at lunch and dinner, paired with richly colored vegetables and a drizzle of olive oil. This supports muscle, keeps you fuller, and stabilizes energy. If appetite is low, consider a simple smoothie with yogurt, berries, and a spoon of nut butter as an afternoon refuel. Hydration matters more than we think in late life. A glass of water mid-morning and mid-afternoon reduces dizziness and confusion for many people. Third, light and sleep. 10 minutes of morning daylight helps reset your body clock, improves mood, and makes it easier to fall asleep. In the evening, lower overhead lights and keep screens away from the pillow. Better sleep sharpens thinking and reduces the chance you'll be labeled confused in a hospital, labels that too often trigger unnecessary tests. Fourth, medications with intention. Once a year, twice is even better. Ask for a deprescribing review. That's a structured conversation where you and your clinician list every medication and supplement, ask what each one is for, and decide which can be simplified or stopped. This alone prevents countless cascades and emergency visits. It is one of the most powerful anti-overtreatment tools we have. Fifth, gentle, food-based supports. Many seniors ask about natural options that complement these habits. Whole food choices like watermelon, beets, and leafy greens can support circulation through naturally occurring compounds. Magnesium-rich foods like pumpkin seeds and dark leafy greens can ease nighttime cramps and help sleep. If you consider supplements, whether for circulation, energy, or prostate comfort, bring them into the same 9-question framework. What decision will this change? What are the absolute benefits and harms? Are we chasing numbers or outcomes that matter to me? And can we try a time-limited trial with clear stop rules? Always check for interactions with your medications and your conditions. Natural does not automatically mean harmless, especially in late life, when kidneys and liver clear substances more slowly. The safest path is collaborative. Bring your clinician into that conversation so your choices remain aligned with your goals. I want to give you a few quick, real-world examples of how the 9 questions protect older adults from harm while preserving what matters most. A 79-year-old man with stable urinary symptoms was pointed toward a cystoscopy just to check. He asked, "How will this change my care?" The answer was unclear. He asked about absolute risks and alternatives. We agreed on a watchful waiting plan with lifestyle adjustments and a time-limited trial of a mild medication. His symptoms eased. No scope, no complications. The decision was not do nothing. The decision was do what helps. A 74-year-old woman was on 3 blood pressure medications that left her fatigued and lightheaded. She asked question 6. Are our targets too aggressive for me? We adjusted to a slightly higher, still safe range and reduced one medication. Her energy returned. She began walking with friends again. Her quality of life, her real medicine, improved. An 85-year-old with mild memory changes was sent for a battery of scans to look for causes. He asked about downstream consequences if something small appeared. The likely result was more tests and no change in treatment. Instead, he and his family focused on daylight, routine, hydration, a deprescribing review, and home safety. His confusion episodes dropped. No cascade, more calm. If you remember only a handful of lines from this video, make them these. What decision will this test change? Show me the absolute benefits and harms for someone like me. Given my age and goals, is there a safer alternative or a watchful waiting plan? Are we chasing numbers or protecting my independence? Can we set stop rules and try small, reversible steps first? These sentences are not confrontational, they are clarifying. Most clinicians who care for older adults appreciate them because they transform rushed protocols into thoughtful care. I also want to speak to the emotional side of overtreatment. Fear drives many choices. Fear of missing a cancer, fear of being blamed, fear of regret. Those fears are understandable, but fear is a poor substitute for wisdom. Wisdom is measured, curious, and compassionate. Wisdom asks, what will help me live the life I want with the time I have? Wisdom knows that more medicine is not always better medicine. Wisdom also knows that sometimes an invasive test is exactly what's needed. When symptoms point to an urgent problem, when treatment can clearly restore function, when the benefits are real and near-term. The 9 questions don't say no. They teach you how to say yes for the right reasons. If you're wondering how to use these questions without feeling like you're challenging your doctor, try this approach. Bring a note card with the 9 questions. At the start of the visit, say, "Doctor, I'm trying to be a good steward of my health. I brought some questions to help me understand what's necessary and what isn't. Then pick 2 or 3 questions that fit the situation. If the conversation gets technical, ask for plain language and practical examples. If you need time, say, "I'd like to talk this over with my family. Is it safe to wait a week?" Most decisions in late life are not emergencies. You're allowed to think. The final piece I want to address is hope. Overtreatment steals hope by making older adults feel fragile and medicalized. The 9 questions give hope back. They remind you that your body still knows how to heal from a good night's sleep, from a walk in fresh air, from a meal with color and protein, from a laugh with a friend, from a medication list that finally makes sense. They remind you that you are allowed to protect your energy, your attention, and your joy. So let's pull the whole message together in one breath. At 70 and beyond, your health is best served by tests and treatments that meet 3 conditions. They meaningfully improve your outcomes within your realistic time horizon. They respect your priorities for independence and clarity. And they expose you to the least possible harm while answering the right question. The 9 questions are your compass. Use them. Share them. Keep them in your wallet. Teach them to your family. And remember, you are not refusing care when you ask for evidence, alternatives, and alignment with your goals. You are demanding the very best care medicine can offer. Now I'll leave you with a gentle, empowering close that you can carry into your next appointment. Take a deep breath. Place your feet on the floor. Feel your strength. When a test is proposed, ask, "Will this change my care?" When a number is too tight, ask, "Are we chasing safety or perfection?" When the plan feels heavy, ask, "Is there a simpler, safer way to reach the same goal?" When fear begins to speak, answer with wisdom. I choose what helps me live well. If this conversation helped you, share it with someone you love who is facing a wall of appointments and lab slips. Add your experience in the comments. What questions have protected you or your family from unnecessary cascades? And if you want more tools like these, subscribe and stay close. In this community, we practice medicine with our eyes open and our hearts steady. We honor the years behind us by choosing care that respects the years ahead. Before we part, let me repeat the 9 questions one more time, clearly, so you can write them down and use them exactly as they're spoken. 1. What decision will this test help us make? And how will the result change my care? 2. For someone my age and health, what are the absolute benefits and absolute harms over the next 5 to 10 years? 3. What is my realistic life expectancy and functional outlook? And how does that change the value of this test? 4. If this test finds something small or unclear, what are the downstream steps, and will they likely help or harm me? 5. Is there a simpler, safer alternative that gives us the same decision-making power? 6. For my chronic conditions, are our targets appropriate for me, or are we being too aggressive? 7. If treatment is recommended, what are the trade-offs in function, independence, and quality of life, not just survival? 8. Can we try watchful waiting or a time-limited trial with clear stop rules before invasive steps? 9. What do respected guidelines say for people like me, and are we following them or departing for a specific reason? Keep those questions close. Use them kindly and firmly. They are your right and your responsibility. I'm Dr. Julia Parker. Thank you for trusting me with this conversation. May your next medical appointment be calmer, clearer, and more truly yours. And remember, after 70, wise choices, not more choices. Protect the life you love.